Hi, my name is Donna Edwards, and today I'm going to be discussing with you substance use disorder treatment for people with co-occurring disorders. Introduction to substance use disorder treatment for people with co-occurring disorder. The key messages here are people with mental illnesses are likely to have comorbid substance use disorders, SUDs, and vice versa. Addiction counselors should expect to encounter mental illness in their client population. Co-occurring disorders, CODs, are burdensome conditions that have significant physical, emotional, functional, and social and economic consequences for the people who live with these disorders and their loved ones. Society as a whole is also affected by the prevalence of CODs. Over the past 2 decades, the behavioral health field's knowledge of outcomes, services, needs, and treatment approaches for individuals with CODs have expanded considerably, but gaps remained in ready access to services and provisions of timely, appropriate, effective, evidence-based care for people with CODs. CODs are complex and bidirectional. They can wax and wane over time. Providers, supervisors, and administrators should be mindful of these when helping clients make decisions about treatment and level of care. You may ask, what is health? The World Health Organization, WHO, considers healthy states ones characterized by complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. HOOD, the Department of Health and Human Services, HHS, Healthy People 2020 initiative also supports a board definition of optimal health, reflected by its outreaching goals of the Centers for Disease Control and Prevention, the CDC. Helping people achieve high-quality, long lives free of preventable disease, disability, injury, and premature death. Establishing health equity, eliminating disparities, and improving the health of all groups. Promoting quality of life, healthy development, and healthy behaviors across all stages. The concept of well-being extends beyond one's physical condition and includes other important areas of functioning and quality of life, such as mental illness and SUDs. The key terms: addiction, the most severe form of SUD associated with compulsive and uncontrolled use of one or more substances. Addiction is a chronic brain disease that has the potential for both reoccurrence, which is relapse, and recovery. Binge drinking, a drinking pattern that leads to blood alcohol concentration levels of 0.08 grams per deciliter or greater. This usually takes place after 4 or more drinks for women and 5 or more drinks for men. The National Institute on Drug Abuse Center for Behavioral Health Statistics and Quality in 2019. However, older adults are more sensitive to the effects of alcohol, and treatment providers may need to lower these numbers when screening for alcohol misuse. Additionally, other factors such as weight, decrease in enzymes activity, and body compensation. Example given, amount of muscle tissue present in the body. It can also affect alcohol absorption rates. Continuing care. Care that supports a client's progress, monitors his or her condition, and can respond 2, a return to substance use or return of symptoms of mental disorder. Continuing care is both a process of post-treating monitoring and a form of treatment itself. It is sometimes referred as aftercare. Co-occurring disorders. We will learn the term that refers to co-occurring SUDs and mental disorders. Clients with CODs have one or more mental disorders as well as one or more SUDs. Heavy drinking. Consuming 5 or more drinks for men and 4 or more drinks for women in one period on each of 5 more days in the past 30 days. Integrated interventions. Specific treatment strategies or therapeutic techniques in which interventions for the SUDs and mental disorders are comorbid. In one session or in a series of interactions of multiple sessions. Mutual support programs. Mutual support programs consist of groups of people who have worked together to achieve and maintain recovery. Unlike peer support groups, example given, recovery youth, recovery coaches, mutual support groups consist of only of people who volunteer their time and typically have no official connection to treatment programs. Most are self-supporting, although 12-step groups, which are Alcohol Anonymous and Narcotic Anonymous, are most widespread and well-researched type of mutual support groups. Other groups may be available in some areas. They range from groups affiliated with religion, church, example given, Celebrate Recovery, or Militai Islam, to purely secular groups, example given, Smart Recovery, Women for Sobriety. Peer recovery support services. The entire range of SUD treatment and mental health services that help support individuals' recovery and that are provided by peers. The peers who provide these services are called peer recovery support specialists. Peer specialists for brevity. Peer providers or recovery coaches. Relapse. A return to substance use after a significant period of abstinence. Recovery, a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Even individuals with severe chronic SUDs can help with overcome their SUDs and regain health and social function. This is called remission. When those positive changes and values become part of a voluntary adaptive lifestyle, that is called being in recovery. Although abstinence from all substance misuse is a cardinal feature of recovery lifestyle, it is not only healthy, pro-social feature. Standard drinking. Based on 2015 to 2020 dietary guidelines for Americans, one standard drink contains 14 grams, that is 0.6 ounces of pure alcohol. A substance is a psychoactive compound with the potential to cause health and social problems, including SUDs. Their most severe manifestation, addiction. The insert at the that you see on the screen lists common examples of such substances. Substance misuse. The use of any substance in a manner, situation, amount, frequency that can cause harm to users or those around them. For some substances or individuals, any use would constitute misuse. Example given, underage drinking, injection of drug use. Substance use, the use even one time of any other substances listed here on this list. Substance use disorder. A medical illness caused by repeated misuse of substance or substances, according to the DSM-5, that is the American Psychiatric Association, APA. Substances, SUDs, are characterized by clinical significant impairment in health, social function, and impaired control over substance use, and are diagnosed through assessing cognitive, behavioral, and psychological symptoms. SUDs range from misuse. SUDs range from mild to severe and from temporary to chronic. They typically develop gradually over time with repeated misuse, leading to changes in the brain circuit governing insensitive salience, the ability of substance-associated cures to trigger substance seeking, reward stress, and executive functions like decision-making and self-control. Multiple factors influence whether and how rapidly a person will develop an SUD. These factors include the substance itself, the genetic vulnerability of the user, and the amount and frequency, duration of misuse. Let's give some categories and examples of substances. A substance category such as alcohol, and the represented examples are beer, wine, malt liquor, and distilled spirits. Another substance category are illicit drugs, which are cocaine, including crack, heroin, hallucinogens, including LSD, PCP, ecstasy, peyote, mescaline, penicillin, methamphetamines, including crystal meth, marijuana, including hashish, synthetic drugs, including K2, spice, and bath salts, prescription-type medications that are used non-medical purposes, pain relievers, synthetic, semi-synthetic, and non-synthetic opiate medications, including fentanyl, codeine, oxycodone, hydrocodone, tramadol products, tranquilizers including benzodiazepines, methorbamate products such as muscle relaxers, stimulants, and methamphetamines including amphetamines, dextromethorphan, and phentermine products, mazidol products, and methylphenidate and dexmethylphenidate products, sedatives including temazepam, flurazepam, or triazolam, and any barbiturates. Over-the-counter drugs and other substances, such as cough and cold medicines, inhalants including aminol nitrate, cleaning fluids, gasoline, and lighter gases, anti-synthetics, solvents, spray paint, and nitro oxide. Prevalence and treatment need of CODs. National surveys suggest that mental illness and SMI in particular commonly co-occurring with substance misuse in the general adult population, and many individuals with CODs go untreated. The National Survey on Drug Use and Health, based on a sample more than 67,700 U.S. civilians ages 12 or older in non-institutionalized setting, offers revealing insights. Notable statistics from the latest survey include the following. In 2018, 47.6 million, that's 19.1% of all adult ages 18 and older had any mental illness during the previous year, including 11.4 million, that's 6.4% of all adults with SMI. Among these, 47.6 million adults with any past year mental disorders, 9.2 million, 19.3%, had also an SUD, but only 5% of adults without any mental illness in the past year had an SUD. Of the 11.4 million adults with an SMI in the previous year, approximately 28% also had an SUD. SMI is highly correlated with substance misuse. Adults ages 18 and older with any past year mental illness were more likely than those without to use illicit drugs or misuse prescription medication. This pattern was even more pronounced among people with SMI. Of the 47.6 million adults with any post-year mental illness, more than half, 56.7%, received no treatment, and over one-third, that's 35.9%, of adults with an SMI in the past year received no treatment. Further, nearly all, more than 90%, of the 9.2 million adults with both past year mental illness and SUD did not receive services for both conditions. About 14.2 million adults, that is about 5.7% of all adults, saw themselves as needing mental health services at some point in the previous year but did not receive it. Of adults with any mental disorder, 11.2 million, almost 24%, or nearly 1 in 4 adults with any mental illness had a perceived unmet need for mental health services in the year. Of the adults with an SMI, 5.1 million, that's about 45% or more than 2 out of every 5 adults with SMI, had a perceived unmet need for mental health services in the previous year. More than 18 million people ages 12 and older needed but did not receive SUD treatment in the previous year. An example given is that they had an SUD or problems related to substance use. Most of those individuals did not see themselves needing treatment. Only 5% thought they needed it. Almost half, 48.6% of adults ages 18 and older with any mental illness and co-occurring SUD received no treatment at all in 2018. About 14% received mental health services. Only 33.3% received SUD treatment only, and 7% received both. Of adults with SMI and co-occurring SUDs, 30.5% received no treatment. About 56% received mental health services only. Almost 3% received SUD treatment only, and about 11% received both. The second one is CODs and hospitalizations. Compared with people with mental disorders or SUDs alone, people with CODs are more likely to be hospitalized. Some evidence suggests that the hospitalization rate for people with co-occurring disorders is increasing. Opiate use disorder and the problems of CODs. Opiate addiction and overdose are a public health crisis and the target of numerous federal prevention, and treatment campaigns. Among the causes for concerns is a high rate of CODs among people with opiate use disorder, OUD. Of 2 million U.S. adults with OUD in 2015 to 2017, the NSDUH 77% also had other SUD or nicotine dependence in the past year. 64% also had any co-occurring mental illness in the past year. 27% had a past year comorbid SMI. In terms of services provision, 38% of people with OUD and any past year mental illness or SMI received SUD treatments in the previous year. Mental health services were more common, with 55% of people with OUD and any mental illness and 65% of those with OUD and SMI receiving care in the previous year. However, comprehensive treatment for both disorders was low and reported by only 1/4 of people with OUD and any mental illness and 30% of the people with OUD and SMI. Number 3 are trends in the COD programming. Some evidence supports an increased prevalence of people with CODs in treatment setting and of programs for people with CODs. However, treatment gaps remain. The fourth one is complications of CODs. CODs can complicate treatments and, if poorly managed, can hinder recovery. Further, rates of mental disorders appear to increase as the number of SUDs increases, meaning people with polysubstances use are especially vulnerable to CODs. Epidemiologists have observed increasing rates of SUD treatment admissions among people with multiple SUDs. But people with multiple mental disorders, particularly mood disorders, PDs, and PTSD, are nearly 9 times more likely to have multiple past year SUDs. Treatment facilities are increasingly seeing non-alcoholic substances as primary substance of misuse among people entering treatment. CODs can be an obstacle for addiction recovery, especially when untreated. Of people who did not complete treatment, 42% had a COD versus 36% without. CODs are strongly associated with socioeconomic and health factors that can challenge recovery, such as unemployment, homelessness, incarceration, which is criminal justice system involvement, and suicide. According to SAMHSA's Mental Health Annual Report in 2017, 29% of people with CODs were unemployed and 50% were not in the labor force. Of people 12 or older with CODs, 7.5% experienced homelessness. Of the people incarcerated in the United States prisons, about 48% have a history of mental illness, of whom 29% had an SMI, 26% a history of an SUD. Of those with mental illness, 49% also have a co-occurring SUD. Mental disorders that commonly co-occur with SUDs, including depression, anxiety disorders, bipolar disorder, schizophrenia, and PTSD, are highly prevalent in people who have completed suicide. These figures reflect the need for specifically tailored COD assessments, interventions, treatment approaches, and clinical considerations. Example given: CODs programming specific to people without stable housing, COD interventions designed for implementation in criminal justice settings. More information about how these variables factor into service provisions and outcomes. The complex, unstable, and bidirectional nature of CODs, in addition to the inducing of mental disorders, substance misuse can sometimes mimic a mental disorder. Thus, it is important to use thorough screening and assessment approaches to help disentangle all symptoms and make an accurate diagnosis. Learn more about screening and assessment for CODs. CODs are not necessarily equal in severity. Often one disorder is more severe, distressing, or impairing than the other. Recognizing this is important for treatment planning and requires a person-centered rather than a cookie-cutter approach to determining diagnosis, comorbidities, functioning, treatment, and referral needs, and stage of change. Models are available to help counselors make such decisions based on the severity and impact of each disorder. For instance, the 4 quadrants model. This classifies clients in 4 basic groups based on relative symptom severity, not diagnosis. Category 1 is less severe mental disorder, less severe substance use. Category 2 is more severe mental disorder, less severe substance disorder. Category 3 is less severe mental disorder and more severe substance disorder. And Category 4 is more severe mental disorder and more severe substance disorder. SUDs, mental illness, and self-medicating. The notion that SUDs are caused in whole or part in by one's attempts to self-medicate symptoms with alcohol or illicit drugs has been a source of debate. The consensus panel cautions that the term self-medicating should not be used, as it equates to drugs of misuse, which usually worsens health, with true medications which are designed to improve health. Although some people with mental conditions may misuse substances to alleviate their symptoms or otherwise cope, this is not always the case. Counselors should not assume self-medication is the causal link between a client's mental disorder and SUD. In conclusion, the COD recovery trajectory often has pitfalls, but our understanding of CODs and COD-specific service delivery has improved over the past 20 years. Despite these advances, specific gaps remain in the accurate and timely assessment, diagnosis, and treatment of the people with CODs. To achieve lower cost mental health services and SUD treatments, better client outcomes, and more positive treatment experience, providers and administrators must collectively place more focus on CODs in their work. By better understanding the risk and the responding to the service needs of the people with CODs, behavioral health service providers can make long-term recovery an attainable goal for all clients with CODs. Next, we'll be discussing the guiding principles for working with people who have co-occurring disorders. The key messages are general guiding principles of good care for people with co-occurring disorder, CODs. Ensure that counselors and other providers, administrators, and supervisors fully meet clients' comprehensive needs effectively and ethically. Counselors should offer clients full access to a range of integrated services through the continuum of recovery. Administrators and supervisors are responsible for the training, professional development, recruitment, and retention of qualified counselors and other professional staff working with people who have CODs. Failure to attain to these workforce matters will only further inhibit client access to care. Several core essential services exist for clients with comorbid conditions, and supervisors and administrators should regularly evaluate their program's capacity and performance to monitor its effectiveness in providing these services and correct course when needed. Many treatment providers and agencies recognize the need to provide quality care to people with CODs, but see it as a daunting challenge beyond their resources. Programs that already have incorporated some elements of integrated services and want to do more lack a clear framework for determining priorities. Addiction counselors might recognize the need to be able to effectively treat clients with CODs, but not fully understand the best approaches to doing so, as counselors and programs look to improve their effective treating this population. General guiding principles. 6 guiding principles in treating clients with CODs. Number 1, use a recovery perspective. Number 2, adopt a multi-problem viewpoint. The third one, develop a phased approach to treatment. 4, address specific real-life problems early in treatment. 5, plan for clients' cognitive and functional impairments. 6, use support systems to maintain and extend treatment effectiveness. Use a recovery perspective. The recovery perspective has 2 main features. It acknowledges that recovery is a long-term process of internal change, and it recognizes that these internal changes proceed through various stages. The recovery perspective applies to clients with CODs and generates 2 main practices and principles. The first one is develop a treatment plan that provides for continuity of care over time. In preparing this plan, the provider should recognize that treatment may occur in different settings over time. Example given, residential or outpatient. And that much of the recovery process typically occurs outside of or following treatments. Example given, through participation in multiple support groups, through family, peer, and community support, including the faith community. The provider needs to reinforce long-term participation in these continuous care settings. Devise treatment interventions that are specific to the tasks and challenges faced at each stage of the COD recovery process. Whether within the substance use disorder SUD treatment or mental health services system, the provider is advised to use sensible, stepwise approaches in developing and using treatment protocols. In addition, markers that are unique to individuals, such as those related to their cultural, social, and spiritual context, such should be considered. Then the provider needs to engage the client in defining the markers of progress in the that are meaningful to him or her to each stage of recovery. Adopt a multi-problem viewpoint. People with CODs generally have an array of mental, medical, and substance use, family, and social problems. Most need substantial rehabilitation and habilitation, such as initial learning and acquisition of skills. Treatment should address immediate and long-term needs for housing, work, health care, and a support network. Therefore, services should be comprehensive to meet the multidimensional problems typically presented by clients with CODs. Develop a phased approach to treatment. Using a staged or phased approach to COD treatment helps counselors optimize comprehensive, appropriate, and effective care for all clients' needs. Generally, 3 to 5 phases are identified, including engagement, stabilization, persuasion, active treatment, and continuing care or continuing care relapse prevention. These phases are consistent with a parallel to stages identified in the recovery perspective. The use of these phases enables the provider within the SUD treatment or mental health service system to develop and use effective stage approach treatment protocols. Addressing specific real-life problems early in treatment. Growing recognition that CODs arise in a context of personal and social problems with disruption of personal and social life has prompted approaches that address specific life problems early in treatment. These approaches may incorporate case management and intensive case management to help clients surmount bureaucratic hurdles and handle legal and family matters. Specialized interventions that target important areas of client need, such as housing-related supportive services, can also help. Vocational services help clients with CODs make concrete improvements in career goal settings, seeking jobs, work attainment, and earned wages. For people in recovery from mental disorders or SUDs, workforce participation is not only valuable because of its economic contributions, it can also enhance individual self-sufficiency, improve self-identity. Example giving help people feel normal as opposed to like a patient. Offer a sense of belonging with society at large. Provide a way for people to build relationships with others and improve quality of life. A view of effects of employment and interventions for people with SUDs found that employment was associated with reduced substance use and more stable housing. Solving financial, housing, occupational, and other problems of everyday living is also an important first step towards achieving client engagement continuing treatment. Engagement is a critical part of SUD treatment generally and of treatment for COD specific because remaining in treatment for an adequate length of time is essential to achieving behavioral change. Plan for clients' cognitive and functional impairments. Services for clients with CODs, especially those with more serious mental disorders, must be tailored to individuals' needs and functioning. Clients with CODs often display cognitive and other functional impairments that affect their ability to comprehend information or complete tasks. The manner in which interventions are presented must be compatible with clients' needs and functionings, such as impairments frequently called for relatively short, highly structured treatment sessions that focus on particular life problems. Gradual pacing, visual aids, and repetition are often helpful. Even impairments that are comparatively subtle, example given, certain learning disabilities, may still have significant impact on treatment success. Careful assessments of such impairments and a treatment plan consistent with the assessment are therefore essential. Use support systems to maintain and extend treatment effectiveness. The multi-support movement and family peer providers, the faith community, and other resources that exist within the client's community can play an invaluable role in recovery. This can be particularly true for clients with CODs, many of whom have not enjoyed a consistent supportive environment for decades. In some cultures, the stigma surrounding SUDs or mental disorders is so great that the client and even the entire family may be ostracized by the immediate community. For instance, some multi-support programs are not very accepting of members with CODs who have psychiatric medication. Furthermore, the behaviors associated with active substance use may have alienated the client's family and community. The provider plays a role in ensuring that the client is aware of available support systems and motivated to use them effectively. Guidelines for counselors and other providers. Providing access, completing a full assessment, providing an appropriate level of care, achieving integrated treatment, providing comprehensive services, ensuring continuity of care. Providing access. Access refers to the process by which a person with CODs make initial contact with service systems, receive an initial evaluation, and is welcomed into services that are appropriate for his or her needs. There are 4 main types of access. Number 1, routine access for individuals seeking services who are not in crisis. Number 2, crisis access for individuals requiring immediate services because of an emergency. Number 3, outreach, in which agencies target individuals in great need. Example given, people experiencing homelessness, who are not seeking services or cannot ordinary in a crisis or crisis services. The 4th one is access that is involuntary, coerced, or mandated by the criminal justice system, employers, or the child welfare system. Treatment access can be complicated by clients' criminal justice involvement, homelessness, or health issues. No wrong door policy should be applied to the full range of clients with CODs, and counselors, as well as programs, should address obstacles that bar entry to treatment for those with either mental disorder or an SUD. Making no wrong door a reality. The focus of no wrong door imperative is on constructing the healthcare delivery system so that treatment access is available at any point of entry. A client with COD needing treatment might enter the service system by means of a primary care facility, homeless shelter, social service agency, emergency room, or criminal justice setting. Some clients require creation of a right door to enter treatment. For example, mobile outreach treatment teams can access clients with CODs who are otherwise unlikely to seek treatment on their own. The no wrong door approach has 5 major implications for service planning. The first one is assessment, referral, and treatment planning across settings is consistent with no wrong door policy. The second, creative outreach strategies are available to encourage people to engage in treatment. The third one, programs and staff can change expectations and program requirements to engage reluctant and unmotivated clients. The fourth one is treatment plans are based on clients' needs and respond to changes as they progress through stages of treatment. The fifth one, the overall system of care seamless, providing continuity of care across service systems. This is only possible via establishment patterns and integrancy cooperation or clear willingness to attain that cooperation. Completing a full assessment. Assessments of individuals with CODs involves a combination of screening to detect the presence of CODs and in the setting where the client is first screened for treatment. Evaluating background factors, example given, family history, trauma history, marital status, health, education, work history, mental disorders, SUDs, and related medical and psychosocial problems. Example given, their living circumstances or employment that are critical to address in treatment planning. Diagnosing the type of severity of SUDs and mental disorders. Initial matching of individual clients to services. Often this must be done before a full assessment is completed and diagnosis is clarified. Also, the client's motivation to change with regard to one or more of CODs may not be well established. Appraising existing social and community support systems. Conducting continuous evaluations, that is, re-evaluating over time as needs and symptoms changes as more information becomes available. The challenge of assessment for individuals with CODs in any system involves maximizing the likelihood of the identification of CODs, immediately facilitating accurate treatment planning, and revising treatment over time as the client's needs change. The 4 quadrants model. Number 3 is less severe mental disorder, more severe SUD. The 4th one is more severe mental disorder, more severe SUD. Number 1, less severe mental disorder and less severe SUD. Second, more severe mental disorder, less severe SUD. In the previous slide, it helps to provide an appropriate level of care. Clients enter the treatment system at various levels of need and encounter agencies with varying capacity to meet those needs. Ideally, clients should be placed in the level of care appropriate to the severity of both their SUD and their mental illness. Severity and levels of care. Models are available to help counselors make treatment and referral decisions based on the severity and impact of each disorder. For assistance with the quadrants of care, also called the 4 quadrants model, is a conceptual framework that classifies clients in 4 basic groups based on relative symptoms, severity, and diagnosis. The quadrants of care were derived from a conference, the National Dialogue of Co-occurring Mental Health and Substance Abuse Disorders, which was supported by SAMHSA and the 2 of its centers, CSAT and the Center for Mental Health Services. The co-sponsors by the National Association of State Mental Health Program Directors and National Association of State Alcohol and Drug Abuse Directors. Achieving integrated treatment. The literature from the addiction and mental health fields has evolved to describe integrated treatment as a unified treatment approach to meet clients' addiction, mental disorder, and related needs. It is the preferred model of treatment. Principles of integrated treatment for CODs. Mental illness and SUDs are both treated concurrently to meet the full range of clients' symptoms equally. Providers of integrated care receive training in the treatment of both SUDs and mental disorders. CODs are treated with a stage-wide approach that is tailored to the client's stage of readiness for treatment. Example given: engagement, persuasion, active treatment, relapse prevention. Motivational techniques, example given, motivational interviewing, MI, motivational counseling, are integrated into care to help clients reach their goals, and particularly at the engagement stage of treatment. Addiction counseling is used to help clients develop healthier, more adaptive thoughts and behaviors in support of long-term recovery. Clients are offered multiple treatment formats, including individual, group, family, and peer support as they move through the various stages of treatment. Pharmacology is discussed in multidisciplinary teams, offered to clients as appropriate and monitored for safety. The example given, the interactions of the medication, adherence and response. Providing comprehensive services. People with CODs have a range of medical and social problems, multidimensional problems that require comprehensive services. In addition to treatment for SUDs and mental disorders, these clients often require various other services to address social problems and stabilize living conditions. Treatment providers should prepare to help clients access an array of services, including life skills development, English as a second language, parenting, nutrition, and employment assistance. Two areas of particular value are housing and work. Ensuring continuity of care. Continuity of care implies coordination of care as clients move across different service systems. Both SUDs and mental disorders frequently are long-term conditions, so treatment for people with COD should take into consideration rehabilitation and recovery over a significant period of time. Therefore, to be effective, treatment must address the three features that characterize continuity of care. Consistency between primary treatment and auxiliary services. Seamlessness as clients move across levels of care. Example given from residential to outpatient treatment. Coordination of present and past treatment episodes, like making sure you're aware of previous treatments given, how the client responded, and the client's treatment preferences. It is important to set up systems that prevent gaps between service system levels and between clinic-based services and those outside the clinic. The ideal is to include outreach, employment, housing, healthcare, and medication, financial support, recreational activities, and social networks in a comprehensive and integrated service delivery system. Continuity of care in outpatient treatment settings. Continuity care and relapse prevention are especially important with this population given that mental disorders are often cynical, reoccurring illnesses, and substance misuse is likewise a chronic condition subject to periods of relapse and remission. Clients with CODs often require long-term continuity of care that supports their progress, monitors their condition, and can respond to a return to substance use or a return of symptoms of mental disorder. Continuity care is both a practice of post-treatment monitoring and a form of treatment itself. The relative seriousness of a client's mental disorders and SUDs may vary different at the time he or she leaves a primary treatment provider, thus different levels of intervention will be appropriate. After leaving an outpatient program, some clients with CODs may need to continue intensive mental health services but can manage their SUD through multi-support group participation. Others may need minimal mental health services but require continued formal SUD treatment. For people with serious mental illness, SMI, continued treatment often is warranted. A treatment program can provide these clients with structured and varied services not usually available from mutual support groups. Encourage clients with CODs who leave a program to return if they need assistance with either disorder. The status of these individuals can be fragile. They need quick access to help in time of crisis. Regular informal checkups with clients also can help alleviate potential problems before they become serious enough to threaten recovery. A good continuing care plan will include steps for when and how to reconnect with services. The plan and provision of these services also makes readmission easier for clients with CODs who need to come back. Clients with COD should remain in contact post-discharge, even if only by telephone or informal gatherings. Increasingly, addiction programs are using follow-up contacts and periodic group meetings to monitor client progress and assess the need for further service. Continuity of care in residential treatment settings. Returning to life in the community after residential placement in a major undertaking for clients with CODs, with relapse and ever-present risk. The goals of continuing care programming are sustaining abstinence, continuing recovery, mastering community living, developing vocational skills, obtaining gainful employment, deepening psychological understanding, assuming increasing responsibility, resolving family difficulties, consolidating changes in values and identity. Empirical evidence related to continuity of care. A systematic review investigating the effects of continuity of care on treatment outcomes for people with COD showed mixed results. Putting in place continuity of care has generally involved linking clients from one level of care to another and providing multidimensional services. Positive associations reported by some studies include better treatment commitment, reduced violent behavior, improved service satisfaction, better generic and disease-specific quality of life, and enhanced community functioning. However, there was no consistent evidence that continuity of care was associated with abstinence. In studies conducted in the United States, continuity of care was associated with reduced psychiatric symptom severity, lower risk of rehospitalization, improved functioning, reduced Medicaid expenditures, and fewer violent behaviors. Guidelines for administrators and supervisors. This section focuses on some key matters administrators and supervisors face in developing a workforce able to meet the needs of clients with CODs. Guidelines to address these core topics include: number 1, identifying and providing to counselor essential competencies, basic, intermediate, and advanced, values and attitudes to be successful in COD service delivery. Number 2, offering opportunities for professional development, including staff training and education. Using effective burnout and turnover reduction techniques, as these are common problems for any SUD treatment provider, but particularly for those who work with clients who have CODs. Critical challenges face SUD treatment systems and programs that aim to improve care for clients with CODs. This section addresses these challenges by discussing how supervisors and administrators can foster more effective COD programming, such as integrating research and practicing into programming, establishing essential services for people with CODs, assessing agency potential to service clients with CODs via adequate and responsive programming. Providers' competencies. Basic competencies are rudimentary introductory skills all counselors should possess, such as performing a basic screening and assessing to determine whether CODs might exist, and if needed, referring more thorough and formal diagnostic testing. Conducting a preliminary screening to determine whether a client possesses an immediate danger to self or others, and coordinating any subsequent assessment with appropriate staff or consultants. Referring a client to the appropriate mental health services or SUD treatment and following up to ensure that the client receives needed care. Coordinating care with a mental health counselor, serving the same client to ensure that the interaction of the client's disorders is well understood and that treatment plans are coordinated. Intermediate competencies encompasses skills such as performing more in-depth screening, treatment planning, discharging, linking clients to other mental health services. Advanced competencies go beyond an awareness of the addiction and mental health fields as individuals disciplines to more sophisticated appreciation for how CODs interact in an individual. This can include understanding the effects of level of functioning and degree of disability related to both substance-related and mental disorders separately and combined. Using integrated models of assessment, intervention, and recovery for people with both substance-related and mental disorders, as opposed to parallel treatment efforts that resist integration. Collaboratively developing and implementing an integrated treatment plan based on thorough assessment that addresses both all disorders and establishes sequence goals based on urgent needs, considering the stage of recovery and level of engagement. Involving the person, family members, and other supportive providers, including peer support and those in the natural support system, and establishing, monitoring, and refining the treatment plan. Continuing professional development. Given the complexity of CODs and lagging treatment rates, there is a pressing need for professionals to develop the necessary skills to accelerate, identify, and manage these conditions. Education and training. Education and training are critical to ensuring professional development and competency of providers and should take place throughout the continuum of one's formal education and career. Various forms of education and training are central to evidence-based, high-quality care for people with CODs. Staff education and training are fundamental to all SUD treatment programs. Few university-based programs offer a formal curriculum on CODs, although the past decade has seen some improvement. Many SUD treatment counselors learn through continuing education and facility-sponsored training. Continuing education is useful because it can respond rapidly to the needs of the workforce that has diverse educational backgrounds and experience. To have practical utility, competency training must address the day-to-day concerns that counselors face on working with clients who have CODs. The educational context must be rich with information, culturally sensitive, and designed for adult students, and must include examples and role models. Ideally, the instructors will have extensive experience as practitioners in the field. Continuing education is also essential for effective provision of services to people with CODs, but it is not sufficient in and of itself. Counselors must have ongoing support, supervision, and opportunity to practice new skills if they are truly integrate COD content into their practice. Program orientation and ongoing supervision. Staff education and training have two additional components. The first one is a program orientation that clearly presents the mission, values, and aims of service delivery, and the second one is strong, ongoing supervision. The orientation can use evidence-based initiatives as well as promising practices. Successful program orientation for working with clients who have CODs will equip staff members with skills and decision-making tools that will enable them to provide optimal services in real-world environments. Avoiding burnout and reducing staff turnover. Burnout. Assisting clients who have CODs is difficult and emotionally taxing. The danger of burnout is considerable. Among mental health and SUD clinicians, the effects of working with clients with trauma can lead to compassion fatigue, viciously traumatizing or secondary traumatic stress. If untreated, these can have profound negative effects on a clinician's ability to function at work effectively, care for the clients, and care for oneself. Program administrators must stray away of burnouts and the benefits of reducing turnover. In order for staff to sustain their morale and esprit de corps, they need to feel that program administrators are interested in their well-being. Most important, supervision should be supportive, providing guidance and technical knowledge. Programs can proactively address burnout by placing high value on staff well-being, routinely discussing well-being, providing activities such as retreats, weekend activities, yoga, and other healing activities at work site, and creating a network of ongoing support. Turnover. The issue of staff turnover is especially important for staff working with clients who have CODs because of the limited workforce pool and the high investment of time and effort involved in developing a trained workforce. Rapid turnover disrupts the context of the recovery occurs. Clients in such agencies may become discouraged about the possibility of being helped by others. Ways to reduce staff turnover in programs for clients with CODs can include hiring staff members familiar with both SUD and mental disorders who have a positive regard for clients with either or both disorders. Ensuring that staff have realistic expectations for the progress of the clients with CODs. Ensuring that supervisory staff members are supportive and knowledgeable about problems and concerns specific to clients with CODs. Providing and supporting opportunities for further education and training. Offering a desirable workforce environment through adequate compensation, salary incentives for COD expertise, opportunities for training and for career advancement, involvement in quality, imperative, or clinical research activities, efforts to adjust workloads. Integrating research and practice. To be effective, resources must be used to implement the evidence-based practices most appropriate to the client population and the program's needs. The importance of the transfer of knowledge and technology has come to be well understood. Advice to administrators. Recommendations for providing essential services for people with CODs. Develop a CUD program with these components. Screening, assessment, and referral for people with CODs. Physical and mental health consultation. Prescribing on-site psychiatrist. Psychoeducational classes. Relapse prevention, case management, COD-specific treatment components, continuing care services, double trouble groups on-site, dual recovery mutual help groups off-site. Establishing essential services for people with CODs. Individuals with CODs are found in all SUD treatment settings at any level of care. Although some of these individuals have SMI or disabilities, many have disorders of mild to moderate severity. As SUD treatment programs serve the increasing number of clients with CODs, the essential program elements required to meet their needs must be defined clearly and set in place. Screening, assessment, and referral for people with CODs. All SUD treatment programs should have appropriate procedures for screening, assessment, and referring clients with CODs. Each provider must be able to identify clients with both mental disorders and SUDs to ensure their access to the need of care needed for each disorder. If the screening and assessment process establishes an SUD or mental disorder beyond the capacity and resources of the agency, referrals should be made to a suitable residential or mental health facility or other community resource. Physical and mental health consultation. Any SUD treatment program that serves a significant number of clients with CODs would do well to expand standard staffing to include mental health specialists to incorporate consultation for assessment, diagnosis, and medication into treatment services. A psychiatrist provides services crucial to the sustaining recovery and stable functioning for people with CODs. Assessment, diagnosis, periodic reassessment, medication, and rapid response to crisis. Prescribing on-site psychiatrist. An on-site psychiatrist brings diagnostic, prescribing, and mental health counseling services directly to the location at which clients receive most of their treatment. An on-site psychiatrist can reduce barriers presented by off-site referral, including distance and travel limitations, the inconvenience of enrolling in another agency, separation of clinical services, that's more red tape for the client, fears of being seen as mentally ill if referred to a mental health agency, costs and difficulty getting comfortable with different staff. Medication and medication monitoring. Many clients with CODs require medication to control their psychiatric symptoms and to stabilize their mental status. One important role of psychiatrists in SUD treatment settings is to provide medication based on the assessment and diagnosis of the client, with subsequent regular contact and review medication. These activities include careful monitoring and review of medication adherence. Psychoeducational classes. Psychoeducational classes on mental disorders and SUDs are important elements in basic COD programs. These classes typically focus on the signs and symptoms of mental disorders, medications, and the effects of mental disorders and substance misuse. Psychoeducational classes of this kind increase client awareness of their specific problems and do so in a safe and positive context. Most important, however, it is that education about mental disorders be open and generally available within SUD treatment programs. Information should be presented in a factual manner. Some mental health clinics have prepared synopsis of mental illness for clients in terms that are factual but unlikely to cause distress. A range of literature written for the lay person is also available through government agencies and advocacy groups. The material provides useful background information on the SUD treatment counselor as well as for the client. Relapse prevention. Programs can adopt strategies to help clients become aware of cues or triggers that make them more likely to misuse substances and help them develop alternative coping responses to those cues. Some providers use mood logs to increase clients' awareness of situational factors that underlie urges to use substances. Basic treatment programs can train clients to recognize cues to return to the psychiatric symptoms, to manage emotions, and to identify, contain, and express feelings appropriately. Case management. CODs are complex conditions that affect many areas of a person's life, including his or her physical and emotional functioning, vocation, education, social and family relationships, and daily functioning. Case management is needed to ensure that clients receive a continuum of support services at the intensity and level needed to meet their service needs and readiness for change. COD-specific treatment components. People with CODs face unique challenges compared with individuals who have only a mental illness or an SUD. For instance, their risk of homelessness, incarceration, and recovery relapse are particularly high. Furthermore, symptoms of one condition can exacerbate the other, especially if untreated, and treatment components should comprehensively address all diagnoses and symptoms. Continuing care services. Long-term follow-up is critical to recovery. SUDs and mental illnesses are chronic diseases, and the clients will likely face struggles, including relapse, long after they leave treatment. Programs have many options for providing continuing care, including mutual support and peer recovery support programs, relapse prevention groups, ongoing individual or group counseling, mental health services, example giving medication checks. For inpatient settings, long-term follow-up should be discussed collaboratively as part of the client's discharge plan, so clients are fully aware of supports and services in place to help them succeed. Double trouble groups on-site. On-site groups such as Double Trouble in Recovery provide a forum for discussing the interrelated programs of mental disorders and SUDs, helping participants to identify triggers for relapse. Clients describe their psychiatric symptoms such as hearing voices and their urge to use drugs. They are encouraged to discuss rather than to act on these impulses. Double trouble groups can also be used to monitor medication adherence, psychiatric symptoms, substance use, and adherence to scheduled activities. Double trouble provides a constant framework for assessment, analysis, and planning. Through participation, the individual with CODs develops perspective on these interrelated nature of mental disorders and SUDs and becomes better able to view his or her behavior within this framework. 12-step facilitation and CODs. 12-step facilitation is a treatment engagement strategy designed to move clients towards participation in mutual support as a part of their plan for achieving and sustaining long-term recovery. Dual recovery mutual support groups off-site. Various dual recovery mutual support groups exist in many communities. SUD treatment programs can refer clients to dual recovery mutual support groups tailored to the special needs of the people with CODs. These groups provide a safe forum for discussion about medication, mental health, and substance misuse programs in an understanding, supportive environment where coping skills can be shared. Assessing the agency's capacity to serve clients with CODs. Every agency that already is treating or planning to treat clients with CODs should assess the current profile of its clients, as well as the estimated number of type of potential new clients in the community. It must also consider its current capabilities, its resource and limitations, and the service it wants to provide in the future. Organizational tasks to determine service capacity include conducting a needs assessment to determine the prevalence of SUDs in the client population, the demographics of those clients, and the nature of the disorders and accompanying problems they present. Data gathered can be used to support grant proposals for increasing service capacities. Determining what changes need to be made in staff, training, accreditation, and other factors to provide effective services for clients with CODs. Assessing community capacity to understand what resources and services are already available within their local and state systems of care before deciding what services to provide. Identifying missing levels of care, gaps in service to help programs better respond to client needs. To clarify the guiding principles and approaches that optimize COD programming success, these elements are further classified into 7 dimensions. Number 1, a structure that offers unrestricted, integrated, collaborative services to clients with CODs. Number 2, a culture that is welcoming to clients with CODs and readily offers education about CODs. Number 3, use of routine screening, assessment, and diagnosis, or referral to diagnosis if needed, for clients with CODs that takes into account each client's severity and persistence of symptoms. Number 4, a clinical process that includes stage-wise treatment planning, ongoing assessment, and monitoring of symptoms of both disorder throughout the course of care, and numerous approaches to interventions, such as pharmacotherapy, management, psychoeducation, and support for the client and for the family, specialized interventions in behavioral health, and peer-based services. Number 5, provisions of continuous care through collaborative approaches, recovery maintenance strategies, and follow-up services, including community-based and peer-based services. Number 6, attention to staffing needs, such as including prescribers, ensuring that clinicians possess required licensure, competency, and experience in implementing supervision or other professional consultation processes, like case review or other formal approaches to staff monitoring and support to ensure ethical, evidence-based care. Number 7, staff training on CODs, including training that imparts basic skills and knowledge. Example given, screening and assessment, symptoms, prevalence rates, as well as advanced training, example giving, specific interventions including basic understanding of pharmacological therapies. The consensus panel suggests the following classification system: basic, intermediate, advanced, or fully integrated. As conceived by the consensus panel, a basic program has the capacity to provide treatment for one disorder but also screens the other disorder and can access necessary consultations. A program with an intermediate level of capacity tends to focus primarily on one disorder without substantial modification to its unusual treatment, but also explicitly addresses some specific needs related to the other disorder. For example, an SUD treatment program may recognize the importance of continued use of psychiatric medications and recovery, or a psychiatrist could provide MI regarding substance use while prescribing medication for mental disorders. A program with advanced capacity provides integrated SUD treatment and mental health services for clients with CODs. In conclusion, co-occurring mental disorders and SUDs are complex. They present significant clinical, functional, social, and economic challenges for people living with them, as well as for the counselors, administrators, supervisors, and programs who treat them. To help address the full range of symptoms clients experience and optimize outcomes, providers and programs must understand the components of comprehensive, high-quality care for CODs and have plans in place to implement core strategies, skills, and services. By using treatment frameworks, philosophies, and approaches empirically shown in the net-based outcomes for people living with CODs, the SUD treatment mental health fields can close gaps in access and treatment so that people with CODs can more functional levels.